Provident Healthcare Partners is a healthcare investment bank that is focused on transaction advisory services. We created this podcast for healthcare executives, entrepreneurs, shareholders, and providers who are interested in learning more about the world of healthcare consolidation.
Good afternoon, everyone, and welcome to another episode of Provident Healthcare Dealcast. This is Craig Sager with Provident Healthcare Partners. I am joined today by my colleague, Dan O'Brien, who's a senior associate on the Provident team. And our featured guest is Chris Bove, who's a seasoned healthcare service operator and current CEO of Clean Slate Centers. I had the opportunity to meet Chris earlier this year at a conference in Nashville, and we had a really good discussion on broad industry points and about Clean Slate. And I was really impressed with Chris, not just because he was an expert in his field, but you could just kind of see the passion that he brings to Clean Slate every day. And so that would be a great idea to get him on the podcast, given all the crossover that we do within behavioral health. So with that, Chris, we'd love to have you give the listeners here a quick snippet of your background, if you'd like to go first.
Sure. Thanks, Craig. And thank you for those kind words. Been with Clean Slate for about 2 years, currently serve as the CEO. And prior to working at Clean Slate, I'd started my healthcare career in correctional healthcare, where we served counties and states and provided all aspects of care for those that are incarcerated, from chronic disease management, emergent care, behavioral health, psychiatric services, etc. And during that time, having worked in nearly 300 plus jails across the country, had the opportunity to see what was taking place with the opioid epidemic. And saw an incredible number of people that were incarcerated really due to the root cause of being addicted to opiates. And that addiction led them to, unfortunately, find themselves in the correctional setting. And it really didn't matter if it was in the state of Washington, Florida, New York, Maine. Those that were incarcerated, you walk through an intake center and you're guaranteed to see somebody that's unfortunately going through withdrawal, 18-year-olds to 80-year-olds. And it really made an impact on me and made me recognize that we've got a serious problem across the country. After leaving that space, I went into the dental space, which private equity-backed roll-up organization, which I truly enjoyed. And we were a specialty dental group focused on pediatric care. But I got a phone call about an opportunity to join Clean Slate. And when I found out the mission and the goals, I jumped at the chance, because I think, really trying to help people avoid the incarceration route, because no matter what progression that's taken place with treatment within inside those walls and how far advanced that has become, and the embracing of the challenges that the sheriffs face, that is still no place for someone that has to face opiate addiction. And so with presented this opportunity, I jumped at it. And so, like I said, I've been here 2 years. I love every minute of it. I love the team, and I love what we are able to do for the communities we serve.
Yeah, Chris, appreciate that overview. Yeah, you have an interesting differentiated background. And I would just say for the listeners, behavioral health it's a really broad industry, right? There's a bunch of different pockets within behavioral health, from mental health, IDD, autism, substance use, eating disorder. This conversation is really going to be around substance use disorder. And then to go one layer deeper, what the industry likes to call it is medication-assisted treatment, or MAT or MAT, which is a space that Dan, myself, our whole behavioral health team cover very closely here at Provident Healthcare Partners, and obviously what Chris and his team lives and breathes every day. With that, Dan, you're sort of our in-house guru when it comes to SUD and specifically MAT. Could you just set the table for the listeners in terms of what's going on in America today from a substance use and opioid crisis?
Yeah, thanks, Craig. I'll piggyback off what you just said. I mean, as a firm, we spend a lot of time tracking trends within the SUD space. And I think, medication-assisted treatment is a small niche there, but one I think that we've really enjoyed following. And it's had an interesting evolution as it continues to take different forms with new strategies, treatments, site of service settings, but really does remain key pillar within addiction treatment services, and does serve as the primary source of treatment for many people dealing with addiction today, primarily those suffering from opioid use disorder, as Chris mentioned. So I'm not gonna say anything novel here. I'm sure, we're all well versed in the pervasiveness of the opioid epidemic today in America, but there's 6.1 million, estimated 6.1 million Americans today struggling with OUD. And what that equates to is nearly 1 in 50 people. And then that number continues to climb post-pandemic. And aside from just the obvious cost that this has on the American healthcare system, it has a broader economic and societal impact as well. The most recent estimates is that the opioid epidemic costs the American economy over $1 trillion per year, which is a pretty staggering number when you think about it. And so I think for the purposes of the podcast today, we wanted to talk with a seasoned industry executive who's been on the front lines and has a good understanding of what works and maybe what doesn't work, and his experience in playing a pivotal role in curbing this opioid epidemic, in America today.
Chris, back to you here. Can you just give the few-minute voiceover on Clean Slate, what your model is? And then I think for some people, right, like this years ago, when I heard medication-assisted treatment, naively, I said to myself, why would you, somebody that has cravings or addiction, why would you then give them medication? If you could just help in an elementary way to define what MAT, what it is, and why it's a treatment model that a lot of companies and certainly Clean Slate employs.
Yeah, absolutely. A high-level overview of Clean Slate. Today, we serve in 8 states across the country. We're providing care for approximately 20,000 patients on an active basis. And we are focused on what you stated, MAT. And what we're doing through our clinical team is visiting with the patients. And most of the time when a patient comes in, they're in a pretty acute state. And so our clinical team visits with that patient and then prescribes them buprenorphine. And that medication is really intended to help address the opiates that are in their system, knock it off the receptors that's in the brain, and then really try to reduce the impact of the opiates in their system and in essence, reduce the cravings and help as they progress through the withdrawal process. And so our clinical team's there during the acute state, and many times the patient's going to come in several times a week and visit with that provider up until the point where they make it through the first several weeks of transition, and then we start progressing them through their journey within the program. And I'd say that's a pretty high level overview of what we're doing. And the reason, there was a lot of angst initially to your specific point of why would we give patients that are addicted to drugs more drugs? And the way this medication is set up is really much safer approach to treatment. With somebody that's currently on opiates, it's not an addictive type drug, and it really helps them progress through their journey and really start through that pace, that part of recovery.
Got it. Chris, can you just profile a typical patient of Clean Slate? I'm sure there's probably a range in terms of the demographic and age, but typical patient, what they're going through, how do they find Clean Slate? Where are they coming from?
Yeah, absolutely. Most of our patients are coming to us from the community resources or family and friend referrals. We do our share of advertising on the marketing side from a SEO on websites and through social media. But I can tell you a majority of our patients are coming through the communities. Many of them, unfortunately, have hit a point in their path where they lost connectivity with their family, lost employment, lost insurance, lost permanent housing. And so, they've, what you would say is hit a point or call it rock bottom, and then they're in need. And through connections, through resources in the community, they're referred over to us and really begin that path. Now, the unfortunate reality is many of them start and drop off and then restart. And it takes several restarts before they really get into the program. After a period of time, it gets real exciting when you see them reconnect with family or get stable employment or stable housing. And so most of our patients are coming through local communities.
And for the listeners, you had mentioned earlier, you guys are office-based. There's a medication, specifically buprenorphine or Suboxone, that your team administers. There's also another model out there that a lot of groups do called OTP, or Opioid Treatment Program, where methadone is the preferred medication. Could you just unpack for the listeners real quick, like, what's the difference just at the core?
What I'd say the difference between the methadone and Suboxone and buprenorphine I'd say that the methadone is more of a controlled substance where it requires a lot more strict oversight and regulatory function. And when a patient begins their treatment path on methadone, it typically requires a daily visit. It's not something that you can necessarily do over the counter. It's not something that they can do as a take home per se. And so it's highly regulated, requires a lot more visits, and requires a totally different facility structure from the maintaining of the methadone. Whereas in what we do, I would say it's considered safer. And I'd say that it allows the patient to continue with their daily lives and not necessarily be required to come in on a daily basis into our clinics. And so I'd say those two approaches certainly, appeal to a different patient population. But I believe ours allows the patient to really engage in an active lifestyle and not necessarily be required to come in on a daily basis.
That's super helpful. Again, people throw out the acronyms OBOT, OTP, but I think that was well said and understood. So Chris, individual comes to Clean Slate, OBOT model with Suboxone. There's, I'm going to imagine, various phases of the patient journey. When they first step into the first day of the clinic, they get into kind of stabilization, then more maintenance. Are these patients with you for a lifetime? Is it 3 months? Like how should listeners think about that?
Yeah, it's certainly not a lifetime. And I think each patient treatment plan is going to be specified to their needs. We do have some patients that have been with us for years, and those patients, I'd say, feel very comfortable with the staff. They have established relationships, and it feels as though that they really feel the sense of coming in as part of their path, and they want to be committed to it. We have some patients after year, 2 years, that feel very comfortable with where they are. They feel confident in their own journey, and then they become, in a positive way, discharged from the program, and that does happen. Typically, a patient's going to come in, as I mentioned earlier, they're going to be in a pretty acute state and high need, and so we'll see them typically about twice a week. And really, the intent is to try to manage through their withdrawal process, make sure we build that relationship, make sure we're running labs to check on their status, and then after several weeks, they'll scale back to call it once a week. We'll do continued follow-ups via telephone to touch base on them, as well as their office visits once a week, and then progress to once every 2 weeks, and then ultimately get into that maintenance stage where they're coming in once a week. And through this journey, most likely, they'll be engaged with behavioral health, hopefully within our own facility. In some instances, they'll be engaged with behavioral health somewhere else in the community, because that's also an integral part of their treatment plan.
Chris, I appreciate you bringing it up. That's where I was going with this next. Outside of the patient receiving medication when they come to a Clean Slate clinic, are there other services, counseling, behavioral health therapies, or other that your team offers? And then secondly, what does the staff look like? Who are in these clinics?
I'll start with Hep C. One thing that we found through the history of the organization is a lot of our patients are positive for Hep C, and found that through treatment, they actually stay engaged with their substance use disorder treatment longer. And we started the process many years ago. We've cured north of 2,000 people of Hep C, and I'm very proud of that. And we continue to grow that program, and we do that across all of our centers. Behavioral health piece is a little bit trickier to explain. And this is, I think, an unfortunate reality that Clean Slate, as well as others in the space, face. When we incorporate behavioral health into our centers, it's very dependent upon the state requirements. And what's truly fascinating is, even though this need is so great, we know that behavioral health is an integral part of the process. Us, as well as others in the space, we engage the patients in behavioral health where we can, but unfortunately, some states have these regulations that make it very difficult, especially when you factor in the payor and the payor mix. And the reality is the regulatory requirements to treat patients with behavioral health, coupled with the way the payor model works, it's not always viable for our organization. And so the reality is, when you're doing behavioral health, it's almost a state by state, completely different model, depending upon what the state's requiring.
I think what Dan and I have seen, and Dan can chime in as well, you're starting to see more so the entrance of virtual care as it relates to MAT. There's just pure play, only do virtual companies. And then a lot of the groups that we've engaged with have some virtual care offering, or at least considering it. Does Clean Slate do that at all, or what are your thoughts on the virtual versus the physical setting?
Yeah, we use virtual, and the virtual that we use is really intended to supplement some of the visits. We want to make sure that we have an environment which is viable for our patients to continue with their treatment. So if it may be an opportunity where we need to bridge some medication, we'll do a telemedicine visit and continue that bridge. We'll utilize it when patients may be remote or weather circumstances or anything along those lines. So we certainly utilize it as a tool. And we look to expand the use of telemedicine for sure. But we're really big believers in that personal relationship. And when you're at a center and you're sitting there and you're observing, you get a chance to engage with patients and you see patients and the relationships they have with the team, it's huge. And I'd say that it makes the biggest difference, especially when we look at some of our reviews. The comments are family. They reference our team as family. And that's pretty moving. And I think telemedicine certainly has a place. And when we think about some of the remote areas across this country, because unfortunately this situation is impacting every single community, there's locations that it's not viable for us to build a location. And so I think that there's a place for telemedicine. I think the reality is you look at the results, and from a long-term outcome retention, I think that relationship's an absolute integral part of the treatment. I think there is a place for it, although I think for us, we see great success with those relationships.
And Chris, just kind of wrap up, kind of call it this operations or patient journey component, but from a management part of the side of the business for you and your executives and leadership folks, and at the clinical level, when you guys think about measuring success, whether it's at the individual patient level or for the population you're serving, how are you measuring this? Is there certain KPIs or ways to track? Patient came in on month 1 and in month 7, they got much better. How do you think about that?
Yeah, we've got an entire team that's focused on taking a look at our data, having the ability to slice and dice it, and really give it in the hands of those that are the decision makers. And the clinical leadership team really takes a hard look at our overall outcomes, specifically to our patients. And you referenced several of them. What is our average retention rate? How often are patients making their appointments? What's the progression of treatment? So when we talk about those that are in acute state coming twice a week, how long is it taking them to progress through the treatment plan? And really, when we talk about outcomes, we're looking at the labs. And we do have UDSs and confirmatory tests that we utilize. Looking at those results and seeing the reduction of opiates, the reduction of fentanyl in the labs over a period of time, and seeing how successful we are in our treatment plan. And that's what we get really excited about, is the true outcomes for our patients. So we look at those from a patient perspective, and obviously, how well are patients attending their appointment? What's the broken appointment rate? How well can we reach out to those that have fallen off of their treatment plan? Those are the types of things we're talking about nearly daily.
And Dan, when we canvass the MAT world, if you will, across the country, there's a number of different organizations, founder owned or private equity backed or what have you. What are you seeing from groups that look to these sort of measures of success, or even the virtual health that Chris hit on? Any interesting models that you've seen that would differentiate a MAT provider?
Yeah, I think Chris touched on this briefly, but I think we're seeing some groups use interesting things around their urine drug and the lab programs where they're using predictive modeling to kind of get a better understanding of what are the tells or what are the people you should be keeping a closer eye on from a recidivism standpoint, and gleaning insights using AI tools for those confirmatory screens. I think some of the other areas we're continuing to see people innovate are around scheduling, right? I think the biggest, Chris can probably attest to this, I think the biggest issue in this space is keeping people in treatment. And, part of that is increasing accessibility and making sure that people are able to make their appointments. And so having flexible scheduling plans, using things like text reminders, shareable scheduling tools to ensure that accessibility is key to keep these people coming back, because that's what's going to ultimately lead to, positive outcomes on the back end.
I think that's a good segue just into sort of the other stakeholders that play a big role in MAT. So Chris, your population, is the funding coming from predominantly Medicaid, or is there some commercial? Can you just educate us on that?
Absolutely. Yeah. It's predominantly Medicaid, 75 to 80% Medicaid, good percentage of Medicare. We've got some self-pay and then some commercial. You certainly see a high percentage of the Medicaid patient population.
We work, Dan and I and team, across a lot of various healthcare service organizations that are heavy Medicaid, behavioral health or other. And, Chris, would you say it's true? It's very market dependent from a, call it economics or funding perspective. I think what we've seen, again, in other segments of healthcare is just there's a lot of inadequate funding, in Medicaid. That's been the case for a long time, and we're starting to see some innovation and improvement. But that's one. And then two, the population, and Dan hit on this, getting them into the clinic is the biggest challenge. You get them there, you guys, you do great care, you're quality driven. What do you sort of see from the lenses of a Medicaid business?
Yeah, I would agree with that statement. Is it market dependent? Yes. And by market dependent, I'd say state by state. I think that to your point of how it's funded, I'd even say even further than that, it's managed care group to managed care group, sometimes even within the same market, and how things are interpreted and how things are reimbursed and how things are reviewed on a regular basis. And I'd say that's probably some of the biggest challenges we have is understanding and navigating those systems. And then I think to your question on the Medicaid population, I think that Dan said it well, is how are you being predictive in your scheduling? How are you looking at your scheduling? Having been in other businesses before, I can tell you that the Medicaid population, unfortunately, the broken appointments higher than you would see in your commercial patient population. And so we do everything we can. And again, referencing something that Dan said, it's those text reminders, it's the follow-up phone calls. We run a call center, and the call center manages the scheduling process. We have a very high volume of patients rescheduling their appointments. So it's a matter of really having a robust training program for our call center to ensure that we can do everything we can to navigate those reschedules, to make sure the patients are coming in, keep them in treatment. That's the key. And I think throughout our organization, the main mantra is let's keep our patients on their journey. And so everything we can to do to reduce those broken appointments is extremely important.
And I imagine, Chris, there's a pretty sizable lobbying and advocacy effort across, you're in 8 states, right? Which means Medicaid plans, if not several more, because if there's managed care Medicaid within certain states, you're going to each and trying to not just get rates up to get them up, but really trying to explain and educate folks on the demand and the need. And, at certain reimbursements rate, the math just doesn't work, right? And that means you have a hard time recruiting providers, and there's really a domino effect. What does that look like though, Chris, in terms of, I'll call it communicating, pushing the payers to understand what the real issue is here?
Yeah, that I wish I had the solution to navigating the payers. It is a big piece of education, and I think you referenced it in the beginning that this falls under a behavioral health umbrella, and then this is a smaller subset of the overall behavioral health umbrella. And unfortunately, when you're talking about dollars and the payers, this is a very small subset of their overall budget. And to try to get their attention and help them recognize that we need to address this. This is, I think everyone knows, this is a national crisis. To get their attention, to make sure that we do everything we can to make this a viable program, and not just what we do, but all MATs. OTPs have been able to negotiate and obtain, I'd say, favorable rate and bundled rates, whereas we have not in the MAT space. And so or in the OBOT space, and we continue to have those conversations. We continue to educate. We continue to talk to the states about the BH requirements coupled with the payer system. It's a constant education. And I think probably the biggest piece of the education process is also the labs. I referenced that earlier. It's a really important piece to the treatment program. How are the patients progressing? Are they staying compliant with their medications? Are they having some slip-ups here and there? How can we help them navigate through those? And the labs are really an important piece to the overall treatment program. And unfortunately, I'm not sure our payers fully understand that. And so it's a lot of education on the lab process. So a lot of meetings, a lot of visits, constant education, and the process continues.
Dan, on the lab front, what have we seen, speaking with groups or just kind of having our tentacles into this space from a compliance regulatory standpoint? Are there bad actors and good actors? How do people approach the lab as it relates to MAT?
I think there's not really a universal answer here on what's considered appropriate and what's not. I think the prevailing theme here, and this is not unique to SUD services, we see it in pain management, orthopedics, and anywhere where you're doing confirmatory lab testing, is just that it's within a reasonable range. I think laboratory testing has been a service line that groups have kind of overutilized in the past. And I think so long as the lab practices fall within, market norms or industry norms for that particular sector and remains as recommended per the treatment program, it would be deemed compliant, quote unquote. I think where groups run into trouble is where their laboratory service line is generating, an outsized portion of the profits of the business, and the volume for that testing kind of falls outside of the industry norms. So that's what I'd say on that, but definitely an area that, especially when we're analyzing a group, and certainly when, a group might be going through a transaction, is getting scrutiny from a potential acquirer, definitely an area of enhanced diligence in this space for those reasons.
I think we've laid out a number of, we'll call it challenges within, not specifically to Clean Slate, but just the broader MAT space, from it being heavily Medicaid, which again in itself is not a bad thing, but it brings certain components that you need to think through. The lab, the general stigma, right, about people having to go to clinic every day. Is there anything else we haven't talked about, Chris, that keeps you up at night, or is just a challenge specific to Clean Slate or the industry as a whole?
I think the thing that keeps me up at night is the fact that we talked about how big this problem is. And the reality is it's continuing to grow. And it seems as though those that are trying to provide the support, Clean Slate, our peers, even the telemedicine groups, OTPs, those that truly believe in harm reduction to those that are truly believing in abstinence, the unfortunate reality is we're really not unified as a country. And when I say that, having conversations with elected officials, many times it's, we're very glad you're here. We're very happy that you are doing what you're doing. But when we ask for assistance in trying to navigate the regulatory requirements coupled with the payer system, it's one of those you've got to talk to the regulatory body, or you got to talk to the payers. And it's unfortunate deflection. And there's truly not this unified front to say, we're going to address this as a country. We are going to address this as a state. I just don't see that. And I think that's some of the most disheartening piece, because we've got a lot of people on the front lines that are working really hard. We've got incredible amount of doctors and nurse practitioners and PAs and counselors and team members at the front desk and teams at the lab that are trying to do everything they possibly can to help the patients through their journey. And I know myself, as well as other executives, becomes frustrating when we run into these roadblocks from those in the communities that we really shouldn't be. And opiate use disorder is agnostic to income, it's agnostic to race, religion, it's impacting everybody. And it just continues to be headwinds from people that we shouldn't be seeing those headwinds from. And so I'd say that's what keeps me up at night, is how can we best advocate for our patients and our team members that are trying to fight this battle in the halls of the Capitol, federal buildings, and with those payer groups. It's just been some of the biggest challenges we faced.
Yeah, well said. It's really hard to measure this. I mean, when you look at, again, behavioral health, SUD, MAT, it feels like we've come a really long way as a society from where we were 20 years ago. But, big but, when you compare that to physical health, it still feels like, and we are in the early innings, right? In terms of moving the ball, certainly with payers and the inadequate funding. The stigma, yes, there's been improvement there, but it's still there. Access issues. So, I think why we're really intrigued, Dan and I and team, is there's just so much innovation and so much work to be done. And it's really leaders like yourself and organizations like Clean Slate that really make these changes, right? It doesn't happen overnight, but it needs to happen. The problem is too big. Dan, from the clouds, if you will, looking at how investors or private equity views the MAT market, can you help the listeners understand how many MAT groups are across the country that have private equity funding. You can ballpark us. And what do investors like about the market? Maybe what they don't like. We've probably covered a little bit of both so far, but what's your take on that?
Yeah, sure. I mean, if you look at the market today, and it really does continue to expand day in and day out, it feels like we're seeing more investment, be it public or private, being put to work in this space. I think there's somewhere between 25 to 35 groups today with private equity backing or venture capital backing that are helping play a role in curbing this epidemic. I believe from kind of an investment thesis standpoint, what do investors like about this space? I mean, first and foremost, there's a growing need, right? There's a supply and demand imbalance, and it's a sad reality in this space, but there continues to need to be public and private investment alike to put to work in helping these people get the access to high quality care that they need and deserve. I think secondly is Craig, you just touched on it, but it's the growth opportunity. I still feel as though we're in the early innings of solving this problem, and it's getting better. We're certainly not there yet, and there's not a one-size-fits-all approach to treatment. There's a lot of wood to chop, and that gets investors excited because they see, the ability to make a difference and help grow. And whether it's through integrating behavioral health solutions or expanding the offering to include services like Chris mentioned, like hepatitis C, or leveraging AI and predictive modeling, the industry is going to continue to evolve and grow, and hopefully, we should see that bear out in improving patient care. Today, only 1 in 5 people who meet the criteria for OUD actually receive treatment. So there's a large untapped market out there of people that need help, and more money being put to work to get treatment at the forefront and get these people into clinics like Clean Slate is going to help.
Yeah, and I think that's all right. And the one thing I would probably add on to that, and we hit on it earlier, but I think it is more unique to MAT than potentially other pockets within healthcare services. But when we think about how Clean Slate, by way of example, tracks outcomes and has efficacy data and KPIs, and if you think about somebody that's in the primary care setting, they might see their doctor once a year, if that, maybe once every 3 years, right? So how do you really know how that patient is doing, right? Completely different condition or lack thereof. But with Chris and his team at Clean Slate and other models out there, they have a lot of touch points with these patients. And when you can get them under the right treatment model to wrap around services, you can really start to see the improvement. I think investors like the idea of that. We know some models out in the country where it's not all fee for service. There's some value-based care or capitated arrangements they're getting kind of pushed out by some Medicaid providers. Again, not everywhere. It's still early, but you don't see that in a lot of pockets in healthcare services. So that's pretty interesting. Chris, before we wrap up here, anything we haven't talked about as it relates to Clean Slate or MAT that you think would be valuable for the listeners?
Well, I think we've covered a lot of ground. I really appreciate you all bringing this to light and having these conversations. It's such important work, and I'm so proud of what our team at Clean Slate's been able to do, but really very proud of what all of the OBOTs have been able to do across the country, because having opportunities to speak to the leadership teams there, we all have the same mission of really trying to treat the patients in the communities and get results to very much what both you and Dan are talking about. Measure results, have success, bring patients into treatment, keep them in the treatment. And however we can do that, talking about the Hep C treatment, behavioral health treatment, all those pieces are so important to the puzzle and really solving this across the country. So I appreciate you guys bringing this to light, and I really appreciate you having me. Yeah,
no, Chris, thank you for the kind words, and it's been an absolute pleasure for folks out there. Please check out Clean Slate. They're doing really, really important, awesome work. Any questions on MAT, SUD, behavioral health, reach out to Dan or I. We love talking about this stuff. Yes, we're investment bankers by day, but this is really important societal issues that we're going through like we did today. So do not be shy. Thanks everyone for tuning in here, and have a great day.